it's Ryan here, and I greet you in Jesus' most awesome name. Welcome to our 74th Mnemonic in Internal Medicine, and today we are addressing the beautiful topic of myeloma-related tissue impairment, and the mnemonic is crab hab. But first, a couple of dad jokes about crabs. What do you call a crab that just got sat on? You call him a crushed Asian. And how do crabs keep in touch? On shell phones. And why is it so hard for crabs to share? Because they are shellfish. Guys, have you ever considered what an awesome, wonderful God we serve? He is the creator of the heavens and the earth and the universe as we know it. The book of Psalm chapter 19 verse 1 says, here the psalmist praises the Lord and says, the heavens declare the glory of the Lord. And the skies proclaim the work of his hands. And what's so amazing is that this awesome, majestic creator of the universe still wants a relationship with you and with me. The book of Revelation chapter 3 verse 20 says, Jesus says, behold, I stand at the door and knock. Blessed is he who answers, that I may fellowship with him and him with me. And I pray that will be the desire of our hearts, to seek and know the Lord, to seek to relate to him on a more personal and a more intimate level. Amen. So let's continue talking about myeloma-related tissue impairment. So this is just a follow-up video from the previous video we've done describing the plasma cell dyscrasias. And in that video, we covered 7 different categories of plasma cell dyscrasia, of which myeloma is just one type. Okay, so clinical features of myeloma-related tissue impairment. First up is calcium, right? So you end up with hypercalcemia, often in excess of 2.75 millimole per liter. And how this manifests clinically, you know, the patients complain of weakness and nausea, abdominal pain, polyuria, and altered mental status. Renal impairment can happen at a pre-renal, intrinsic renal, and a post-renal level, right? So in terms of the pre-renal, you may have nausea and vomiting with volume contraction and diminished renal perfusion, and you may have renal vein thrombosis. Intrinsic renal impairment can be because of multiple things. Number 1 is myeloma kidney, inferring tubulointerstitial damage from increased light chain absorption at the level of the proximal tubule. Number 2 is plasma cell infiltration. Number 3 is Bence-Jones and Cast nephropathy. Number 4 is amyloidosis. Number 5, light chain deposition disease. Number 6 is hypercalcemia in the way of nephrogenic diabetes insipidus. Number 8 is cryoglobulinemia. Number 9, pyelonephritis. Number 10, sepsis. So multiple ways where you have intrinsic renal impairment. In fact, 10 of them that we just mentioned. Okay, and then on a post-renal basis, you can have renal stones coming from uric acid and a neurogenic bladder. All right, anemia as well is a feature. And here we're talking about, you know, a hemoglobin which is generally less than 10 gram per deciliter, or there's a significant drop, right, by at least 2 gram per deciliter, right? We can also have anemia in the setting of pancytopenia as well, right? And that will manifest clinically with weakness, fatigue, infections, gingival bleeds, ecchymosis, epistaxis, menorrhagia, etc. Now, bony lesions, there's numerous bony lesions which can also happen, all right? And these will manifest with usually lytic bony lesions and fractures. Now, other features, you know, also include hyperviscosity, amyloidosis, and recurrent bacterial infections, because we know that myeloma causes an immunopoiesis of sorts, which lends itself to these things, right? Okay, so diagnostic clues, guys, in the way of myeloma is the presence of tissue impairment in terms of the crab hab features that we discussed, and that suggests either multiple myeloma, where we usually have a high M protein, or amyloidosis, where we have usually a low M protein. Now, AL amyloidosis is characterized by insoluble toxic amyloid precursor light chains, aggregates, that deposit in the tissues in antiparallel beta-pleated sheet configuration. The absence of these crab hab symptoms suggests MGUS, which is, myeloma of undetermined significance, right? Or smoldering multiple myeloma. Other clues can be your quantitative immunoglobulin, which is typically decreased in terms of the serum levels of normal polyclonal immunoglobulins in multiple myeloma. However, this may also occur in MGUS. You have Bence-Jones proteinuria as well, which is the presence of monoclonal light chains, especially above 1 gram per day in the urine, which suggests multiple myeloma. And you also look at the serum M protein level. The higher the level, the higher the likelihood of multiple myeloma. Okay, So investigations, guys, basics, we do our labs. We do a full blood count with a differential, a peripheral smear. You can do electrolytes, urea, creatinine, very important, calcium, magnesium, phosphate, beta 2 microglobulin. You can also look at serum viscosity and a quantitative immunoglobulin, albumin. I think serum protein electrophoresis is really the main investigation, together with urine protein electrophoresis. You can do a 24-hour urine collection for Benz-Jones protein as well. Imaging, very important. A skeletal survey, right? And then a bone marrow biopsy, where you quantify your percentage of plasma cells in the bone marrow. All right. How do we manage multiple myeloma? So generally, if the patient's age is below 65 and they're otherwise healthy, we want to aim for curative therapy, right? So induction chemotherapy with bortezomib plus dexamethasone is our first choice, but you can also use lenalidomide plus dexamethasone, or bortezomib plus thalidomide plus dexamethasone, or bortezomib plus doxorubicin plus dexamethasone, or bortezomib plus lenalidomide plus dexamethasone. If there's a good response, we can proceed through to high-dose melphalan followed by autologous stem cell transplant. Post-stem cell transplant maintenance therapy with lenalidomide is recommended. However, if the patient's older, with the age above 65 and has significant comorbidities, then we just aim for palliative therapy. If there's body disease, don't forget we have to add our bisphosphonates like alendronate or zoledronic acid. Supportive measures is hydration, especially if the patient has hypercalcemia, at least about 3 liters per day. And if the patient has significant hypercalcemia, consider hydration plus prednisone, 25 milligrams QID plus a bisphosphonate. If the patient has renal insufficiency, we want to address the underlying cause. Obviously, if there's infections, you want to get antibiotics on board and consider IVIG as a last resort if there's recurrent infections despite prophylactic antibiotics. If the skeletal lesions, get our bisphosphonates on board. If there's anemia, especially with the HB below 9, consider transfusion, and they usually respond to an erythropoiesis stimulating agent, although one should exercise caution given the increased risk of thromboembolism in these patients and death. Hyperviscosity, you can use plasmapheresis for prophylactic anticoagulation as well, especially if you're on thalidomide or lenalidomide and chemo. Now, for smoldering myeloma, there's no treatment. We just follow them clinically. And for MGUS, which is monoclonal gammopathy of uncertain significance, there's no treatment. We follow them clinically. All right. So there you have it, guys. CRAMP have features of myeloma-related tissue impairment. God bless you.